Buon pomeriggio e benvenuti.
Good afternoon and welcome to the 42nd edition of the meeting. We are now here in presence, but we're also connected in streaming. Today we're going to focus on a very important topic because it highlights a trend for future healthcare systems. Today we're talking about digital health and community medicine. We have two distinguished speakers with us today. We have two colleagues who have a long-standing career and are very qualified on this topic. And I will introduce them to you. And thank you for being here with us. So welcome to Anna Odone, Professor of General and Applied Hygiene at the University of Pavia. Thank you for being here, Anna. And thank you very much to Father Benanti, who is a professor at the Pontifical Gregorian University in Rome. He is an expert in bioethics and ethics of technologies. So he is very qualified on that. So let's have the first slide to introduce the session. This topic focuses on the future of the national healthcare systems. Many challenges that you can see here on the slide were already there before the pandemic. Actually, the pandemic has further accelerated these challenges, such as digitization and community medicine. However, what we also have at stake is the reduction of inequalities. We also need to manage population aging and demographic decrease. We need to interact to combine the social sector and the healthcare sector, and we need to promote health. And also, we need to support scientific progress and technological innovation, which is one of today's topics. I will ask Professor Anna Odone the following question. Under these very difficult circumstances, in this difficult year where we have been fighting against the pandemic, and where we need to focus on primary care, how does community medicine or primary care need to change? Good afternoon to you all. It is a real pleasure for me to be here at the meeting this year. Warm thanks to Mattia for introducing today's session, focusing on two very priority topics for healthcare in Italy: community medicine or primary care and digitization. There is not a chance that community medicine or primary care and digitization are included in mission number 6 of the National Resilience and Recovery Plan. However, before dealing with the topic, let me say something here at the meeting, because the meeting promotes a cross-cutting dialogue. We can all embrace the same behaviors, all professionals and all different perspectives, based on what is stated in our constitutions. In Article number 32 of the Italian Constitution, and I quote, "The Republic protects health as a fundamental right of the individual and the collective interest." Now, as a representative of public health care, there are two ideas in this article. First, the Italian Constitution protects not just the individual health, the health of the eye, but also the health of the community. And the pandemic emergency as well understood the concept of protecting a collective health. Also, we protect not the patient, but the person, the individual. So since we're talking about community medicine here or primary care, prevention must be at the forefront rather than care. So once the objective has been clarified and once the government responsibility has been clarified, we can better understand how policies can safeguard the right to health. The right to health is implemented by local policies and healthcare policies. And indirectly, it can also be implemented by the concepts of health protection in all policies, such as environmental or economic policies, so that indirectly they can protect health by controlling health determinants. In institutional texts, we talk a lot about health in all policies. But we deal with health protection through the different healthcare levels. So there's a list of healthcare services that must be granted by the state. And they are divided into three levels: hospitals. So the patient who is diagnosed with a disease is treated in hospital, then prevention, which is what we're dealing with, and primary care. What is primary care and what is community medicine? It is important to give a definition. So when talking about that, we are talking about basic health care, outpatient health care, home care at a local level. So reference is made to the first access to care, the first line of access to care. The pandemic, as Mattia said, has highlighted that primary care is fundamental to protect the right to health. Italy is now radically changing its policies. There are different models that are being implemented in Italy by different regions. However, the dramatic experience of COVID has taught us that primary care must be strengthened and changed. Primary care is just the way to access the healthcare system. It is the most inclusive, the most equal, and the most effective approach to pursue healthcare objectives, but just in theory. The European Union defines primary health care as a delivery of services which are universally accessible, integrated, man-centered, person-centered, in order to meet most healthcare problems of individuals and the community. Services are provided by staffs, multidisciplinary staffs, together with their patients, hence there's direct collaboration with patients who are being delivered healthcare services and their caregivers at a local level. So people should not go to hospital if primary care is effective. And this is necessary under these current circumstances where population is aging. And it is very important to manage chronic diseases. So primary health care, together with the social services, should prevent people from going to hospital, should not go, for example, to first aid services. And once they come out of hospital, people should be entitled to continuity of care. A national and regional debate is currently underway on reforms and primary healthcare reforms. Primary healthcare is now being reformed in order to pursue this vision through the planning, the strengthening, and the enhancement of local services. However, there are still some remarks I want to make on the reforms, which is currently underway, especially after the COVID experience. So there are some models and standards in order to develop primary healthcare in our national healthcare system. Proximity is very important. And proximity is based on the development of community clinics to host the population, to receive the population. Also, home care should be strengthened thanks to the collaboration with multidisciplinary staffs, and medicine should cater for all the different needs and take into consideration all different risk factors. Then I'm not going to further dwell upon that. However, these are the main elements of the local reform, which is underway. The models that have been proposed have been implemented by the National Recovery and Resilience Plan. Half of the funds allocated to healthcare are used for proximity care and primary care at a local level. I hope you can read the slide. Here you can see the general objectives of the first component of the National Recovery Plan, and services here should cater for local needs. It is also important to strengthen healthcare services and facilities, proximity healthcare services and facilities and home care, and all that should be done thanks to the new digital tools, which should further strengthen primary health care. Thank you, Anna, for this general overview of this topic on the relation between hospital and primary health care. This is something that Italy has been debating for a long time, and it is now trying to transform all that into a reform and into an actual policy. Father Benanti. Now there are new models for primary health care. Here we have with us young general medicine doctors in the room. What do you think about that? What should the primary health care do?
Thank you for inviting me. It is always a pleasure for me to come here to compare my ideas with yours. Before answering the specific question, I would like to take a step back. We should not take for granted the perspective from which I start. What does it mean to deal with proximity care from the point of view of who deals with ethics of technologies? Well, this topic may seem strange because when you think about technological artifacts, there were two ethical perspectives. The one of the user. In the 1990s, I have a hammer which has a handle. The way in which the hand uses the hammer depends on how I use the handle. I can either use the hammer to break coconuts to give them to hungry people, or I could use it to damage, to hurt somebody. And then there was another ethics, that of the engineer. If I have a scalpel to be used in the operating theater, the standards and the professionalism with which this scalpel was designed make the designer responsible for the activity of the surgeon. This is not enough because there's a new wave of demands to technology, new way of questioning technology, which we call ethics of technology. A professor of mine, I studied with him in America, always made this example when talking about ethics and technological innovation. If we go back to the story of New York, a metropolis, Richard Moses is a famous politician linked to New York. Starting from the 1940s, Moses built Manhattan the way we knew it today. The way we know it today. If we have a look at the highway, the parkway, the big six-lane highway linking New York with Manhattan, we see concrete bridges and an asphalt, a tarmac highway. But we should question, what does this mean? If we read a big book, the biography of Moses, written by a Pulitzer Pulitzer Prize winner, we can understand that this gentleman had his own view on the town, and the most beautiful beach of Long Island had to be usable only by the white middle class. So he decided not to have trains reach Long Island, and he had bridges built instead, and they were lower than the standard height. They could only be crossed. The bridges could only be crossed by car and not by coaches, not by buses. And this is the question of ethics of technology vis-a-vis innovation. Each technological artifact means using the power in a non-neutral way. So in the algorithm, today, the new concrete bridge and the highway is a new is innovation use. Those of us who have received the vaccine know that we had to use a portal in order to receive the vaccine. How many rights may be demanded by citizens depend on the way we structure this facility. So the ethics of technology questions, what does all this mean? What does it mean to talk about proximity medicine in the era of the algorithms? I'm going to comment on a video related to the UK. Let's see how they have tried to spend less when it comes to digital medicine. So this is an interface which is called BabylonNet. So the physician is the picture-in-picture, the small picture. The physician is talking with the patient. She answered several questions via the smartphone. Then some questions are suggested to the physician, and the physician will ask this question, will make these questions to the patient. the digital system is reading the emotional feedback of the patient. And you see the different colors. On the right-hand side, you can read all the entire dialogue between the patient and the physician. Now the patient is a little bit confused because the physician is using a technical term. Then the physician used simple terms, and the patient understood the question better. So an annoying headache with some sort of dizziness or vertigo on the part of a patient, according to the diagnosis of the machine, is a Meniere syndrome, something annoying but not so serious. In the upper side, left-hand side, you see the real-time updating of the medical record of the patient, and you see the digital twin of the patient. And on the other side, you see several words. HPI means personal diagnosis. I have a headache. Family X is the family history, and then such a each X is the social diagnosis. All the people living in my street suffer from headache. Is it something which relates to me or which relates to the entire area where I live? At a certain point, the physician said, I agree with the AI. You are suffering from a Meniere syndrome. The entire record is updated. The recipe is prepared. And after 30 minutes, the patient will find the recipe, the prescription, sorry, in your at your chemist. Otherwise, the physician may prescribe a painkiller, for instance. So as you can understand, this system, which is already being used in London, and it is being advertised in the tube stations in London, enables a great gain from an economic point of view, because the last mile is the most expensive part of healthcare. The last path I have to cover in order to reach the patient. The most costly part is not that of the majority of the miles of fiber lines. The most expensive part is the last mile, because that's the most expensive part. And that kind of digitalization enables us to digitalize the last mile. So you receive the physician via streaming connection. In the YouTube advertising, the advertising reads, why should you wait days to see your physicians? You can have a Skype call with your physician, and you will have it ready. You will have a prescription ready in no time. This system seems to be functioning properly. But what kind of rights are exercised or denied in the case of a system such as this one? Well, the first question may be understood by using the word globalization. As you saw, the physician has a specific ethnical features. He's an Indian of Sikh, and he has a beautiful South London accent. But if you have a look at what happens with the biggest telephone answering machines, you see that there are many physicians who are chosen because the patients feel more confident to talk with them because they recognize their own accent. When you call a call center, maybe you have spoken with somebody who's called Marco from Albania, and so you may have some sort of mistrust towards a person who's not Italian. So the same service provided from Bangalore, of course, will cost a lot less. So a service which may be less expensive somewhere else becomes the object of competitiveness. So de facto, there was a profession which in the past was linked to the Hippocrates Oath, becomes a sort of food delivery. The more you work, the more you earn. So the market completely changes. its composition. And the second question, the second issue, is that of the human relationship with the patient. I am a friar, so I'm always keen to having a personal relationship with a patient. A medical diagnosis is not a heartache. It is a person suffering from heartache, somebody who needs human interaction, somebody who is in need of something, somebody who needs to be catered for by another human being, who is in this case a caregiver, a physician, promising a treatment, a care. So medicine is not simply a service. The third question, the third issue, relates to the value of all this, not simply when it comes to to the individual diagnostic action. So Babylon Health entails the fact that the platform works not only with me and my conditions, but also with all the data referring to myself. For instance, we know how the condition of an entire cluster of population or entire nation is proceeding, is going on as a trend. And this means having a power, because we may be able to say to an insurance company exactly how much an insurance policy for that person will cost, depending on the health condition of this person. So AI applications are predictive, and therefore they have a value. They are predictive in the sense that if I use an AI algorithm to the vibrations of an engine, the alteration of vibrations tells the algorithm that the engine will break in 10 minutes, 15 minutes, or 1 hour. So the consumption of drugs using an algorithm can tell me how many drugs and which kind of drugs will be used and will be needed in a certain period of time. And this means having the power. The third instance is the professionalism of the physician himself. I'll give you a trivial example. I still remember the phone number of one of my dearest friends I played soccer with when I was a kid. When it comes to the people I often see today, I cannot remember by heart any number, because I have all the numbers stored in my smartphone. So those who know a little bit about urgency healthcare know that you have 180 strokes in order to attempt to resuscitate a person, whereas the AI has more. And now the healthcare worker has a certain amount of time to decide whether to turn off a machine or not. It requires a different training, and it requires a de-skilling of the physician, which will be difficult to be recovered later on. A physician using for several years a cognitive interface of the machine, to what extent is this physician going to have a de-skilling? And if the diagnosis will be made with a certain bias, how will it be possible to correct this mistake? So the answer may be given by us all, or by us all together, but the physician must understand and must remember that no artifact is totally neutral. The choice we make is going to be the first value we give to a person. It may be an economic value, or it may be another kind of value we attach to the person. And there we wonder what kind of dignity the individual patient has. Thank you very much for this contribution, which is really suitable and adequate for this meeting. These topics are part of the current agenda, and they need to be evaluated within the panorama of the scenario of the development of the NHS.
Digital Health della Società Europea di Sanità Pubblica. Anna
O'Donnell is also the president of a public healthcare association. So what kind of technology what kind of role can technology play helping human beings?
My short answer is that I don't think we're ready for a Health Babylon. But I'm being provocative here. maybe you have seen that everyone, all documents are speaking about the digitization. And before I finished off saying that one of the tools to support the strengthening of primary care is the strengthening of digital tools. So we could say that digitization is the tool in order to achieve the objective I mentioned before, as in to protect the right to health. And to us, digitization is a tool in the healthcare sector. In the European Association of Public Healthcare, we have worked a lot before COVID on the concept of digitization in healthcare. And it is important to provide a definition because it is difficult to define digitization. When talking about digitization in healthcare, what are we talking about? A lot of work has been done by this working group. This report has also been published, and it has defined the digital technologies used in medicine. In that case, we're talking about artificial intelligence, digitization of healthcare data. So a list of digital technologies has been made based on two concepts. First, that the community at large is becoming more digital. The digitization of society is now changing the way in which we promote values. And the healthcare sector must be ready because digitization is a process underway, and that will change the way to deliver healthcare services. It will also change the role of healthcare operators, and it will increasingly change the delivery of healthcare services. So this is not a process that we only have to accept in the healthcare sector, but we need to be empowered, and we need to understand it in order to control it. Digitization must not change in any possible way the objective that we mentioned beforehand, as in the protection of health through a universal, equal healthcare system. Hence, digitization must be a tool. But how can that be done in practice? So, digital technologies that can be used have been defined. But we've not said that in Italy we have the necessary prerequisites, but the starting point is not that good. This is the Digital Economy and Society Index, and you can see that in countries like Scandinavian countries, like Sweden, Denmark, Finland, are the most digital countries. Italy is ranking among the last countries with digital companies, which does have repercussions in the healthcare sector. Now funds will be available to digitize healthcare, but the starting point of Italy is certainly not that high. So what should be done? We need to ask ourselves some questions and provide the right answers, as in, what are the digital technologies for healthcare? Are we talking about robots? Are we talking about apps for mobile phones? How can digitization help achieve the objectives of the healthcare sector? And what are the problems related to the digitization process? and how can those problems be solved. Here you can see a classification of digital technologies, and the idea would be to make a difference between telemedicine and digital medicine. This is one of the topics we are focusing on in the healthcare reform in Italy. Then there are digital technologies connected to machine learning, artificial intelligence, and robotics. They are used for diagnosis and for treatment and rehabilitation. And then there's genomics. So the first point is to understand what is at stake here. This is a very complex process. Then we would like to understand how digitization can help achieve the objectives. The European Working Group has proposed a conceptual framework. It is a very theoretical one, which has identified the characteristics of all digital technologies that can help achieve the healthcare objectives. And they can be classified as such, as you can see here. Certainly, digital technologies can promote a personalization and precision approach with the identification of risk factors, with precision medicine. Then digital technologies can promote automation for many processes. And then they have a predictive power. Then you can see that in data analytics, there's an enormous number of data that can be digitized. And then digital technologies can interact very well. They can interact with the individual, with patients, through digital communication. This is a theory, but since we need to talk about primary care here, how can this conceptual framework be implemented at a local level? The National Recovery and Resilience Plan mentions telemedicine. A lot of things can be said in order to understand how all these characteristics can support primary care. For example, the digitization of information flows is by far not banal. Also, the monitoring system of infectious diseases is not banal at all. The digitization of healthcare information flows is lagging behind in Italy, and this is not Babylon. This is not a diagnosis made by a robot. Here we're talking about the digitization of the electronic health record. This is the primary need for digitization. We need to digitize data, and we need to link the different information flows, because that enables planning, long-term planning. It enables us to identify healthcare needs. And it also assesses the performance of healthcare services, and it is an enormous potential for research in the healthcare sector and in terms of organization. Also, it can promote the integration of different services. Then there is telemedicine. How can telemedicine support the integration among different multi-professional staffs, and how can it better deliver healthcare services at a local level? Well, digitization in the healthcare sector shifts the idea from care to prevention, because we would like to have patients who are better able to control their systems through apps, through wearables, through self-monitoring systems. In so doing, we promote prevention rather than care. Similarly, international organizations are now discussing about a patient or individual-centered medicine. Therefore, digitization promotes people-centered care. And in theory, through digitization, healthcare services, more effective healthcare services can be delivered. They can also be cheaper and safer at the same time. Is this true? Well, this is a theory. There is some scientific evidence showing that this is possible. However, there are some problems that the Americans would call rather opportunities, but we see them as problems, and they have partly been mentioned by my colleague here. So what are the problems connected to this strong potential? Well, the fact that we're not sure whether digitization is not increasing inequalities in healthcare. Who has access to digital services? The elderly, those that are most in need of healthcare services. Hence, we're talking about the digital divide and digital literacy. How can we understand if digitization is working? In university, the data quantifying the impact of some digital technology is still not supporting the introduction of digital technologies in terms of cost containment and in terms of improvement in standards. So even if digitization is good for healthcare, maybe scientific evidence showing its effectiveness is still not enough. And then there should be another session on the interaction between doctors and patients. And then there are also problems connected to safety and privacy. So overall, digitization of primary care and of the healthcare sector must be integrated into a system where all the pieces of the jigsaw puzzle are considered. Political commitment, for example, which we do have, because in Italy and Europe, a lot is being done at a political level on digitization in the healthcare sector, and not only. Economic investments and technical infrastructures. And here we have an engineer. Technical infrastructures must support what we want to do. Also, education and training. We train doctors in public health care, and we need to change the way we train so that future doctors can exploit and use the potential of digitization, then research, and then monitoring and evaluation of what is now being implemented, not taking into account the economic interests of those promoting digitization. So the topic is quite complex. Thank you very much to Professor Arnaudone for two reasons. First of all, because you made us easily understand a very complex topic. And second, because you mentioned two things that are very important, as in mission and the objectives. Clearly, digitization is a tool, We all work in the healthcare sector, and we're all doctors because we wanted to contribute to the common good. And we wanted to take care of the community and of individuals at difficult times. Father Benante. What are the most important technologies among the list? And what are the technologies that would bring more value?
Well, the question is too attractive. Between the cloud and heaven, I bet on heaven. But having said that, I am not a pessimist person when it comes to technology. It's true that in the relationship between the physician and the patient, I see a relationship between two people, and we would need 3 meetings. But this happens in a non-neutral environment because it happens in a healthcare facility. Here, digitalization has an enormous effectiveness and power. I'll give you a couple of examples. A flight. I went to have a test, a simulator of a Boeing 737, a test flight from London to New York. At a certain point, we felt vibrations on the engine. It is an air vacuum, but there were 3 nozzles of the turbine that were that had some problems. And I was told, okay, you're the pilot, you're going to decide whether to go on or to stop. That incident would have remained on a paper note filled in by the pilot once after landing. All the analysis remained as a track. So there were tracks of the analysis. Data was sent to the facility, to the pilot, to the aircraft owner, and to the facility in charge of the repair. So all the data are made available immediately along all the supply chain. If we do not control the supply chain, if we do not control all this chain of data, the data may end up in the wrong hands. So where would I bet? With the ASL, which is very courageous, in the territory around Rome, which is quite a challenging territory. There are hills, there are many tourists, and all the villages. We started a project called Connectoma, unblocking the data produced by the organization during the functioning because, so that they create value for the organization itself. So the hospital can have this data to be made available at any given moment. If I have a person with several traumas in the ER, the system can tell me that if I ask for a TC scan, now I will need 40 minutes or 30 minutes. The diagnostic action is mine, but I can give a list of several actions to be carried out to cater for that patient, and so everything responds to the demands of the healthcare working, catering for that specific patient. Another example, the management of the operating theaters. They should revolve around the patients, but in many cases we have paper lists. Just imagine we could unblock them this way, carrying out that same operation that Steve Jobs did when he presented the first iPhone, and I was there. He took the best smartphones on sale at that time, a Motorola, a BlackBerry, which was a best-selling item, and he said, look how beautiful this is. This is a button, this is a function, we have a specific function, but we have a problem. It does only this. It does only that. My phone has no buttons, but the surface is called smart. It adapts, it adjusts to my requirements. So this is what digitalization can do to the entire healthcare facility. It can make the facility smart. responding to all my demands when I have to cater for a patient. If I had to bet on something, I would bet on this. I would bet on the fact that we will win this battle only when we are no longer dependent on brickwork, on the walls, only if we manage to make facilities smart enough to respond properly to the demands of the specific patient that we have at that specific moment. Digitalization can enable us to carry out all this and in a less expensive way. But I am an expert in ethics, so I always have to focus on the negative questions. We need interdisciplinarity. Engineers are not enough. Physicians are not enough. We need the entire civil society. We need philosophers. We need experts. We need politicians, decision makers. And this meeting is an opportunity to ask questions to the civil society. What is the most known medical device due to the pandemic? The oxygen meter. The oxygen meter is gauged on the white skin. Only one did not depend on the white skin tone. This means that 93% of oxygen saturation in case of white skin is read as 93, but it is actually 87 in a non-white skin tone. So if we do not enter in an ethical way, and if we do not use interdisciplinarity vis-à-vis the process of digitalization of medicine to induce choices made by other people, and in this case we would induce and we would cause inequalities which result from decisions responding to logics such as economics. Those who deal with research in drugs, who said that pharmacodynamics is the same in men and women? It is different. Who said that half the dosage is the suitable dosage for a kid vis-à-vis an adult? So we can say I in a context of we, of us, because the healthcare system in Italy is public. It's a public system, and it caters for the wellness of all people. And this is where we should bet. It should not become simply a mere economic advantage within a total budget for a healthcare facility. Thank you very much. Well, you touched upon a very important topic for us. So we have 3 minutes left, so I will have a very brief last round of questions using a sort of provocation. If we were to read this hour of work together synthetically, in a synthetic way, who is the farthest vis-à-vis this awareness, this sensitivity we've tried to represent in this pathway? Is it the NHS? Are we talking about the citizens? Are we talking about the professionals? Who are the, to say the other way around, who are the most important allies we should have to try and ride this opportunity, take this opportunity, namely digitalization, trying to abide by medical and ethical parameters? Well, I think that the road to success is a road to collaboration. Stakeholders should all contribute to digitalization, bearing and bringing their own different interests. So it is important for us to have interests of everybody converge towards the same, to a common goal. And through this, I think that we could manage. I totally agree. As a professor, when I worked in the US, I worked with a very famous physician, and he talked about the relationship between patients and physicians in a very emphatic way when he gave the white uniform, let's say, to the new physicians, and he was very rhetoric. He talked about alliance. We do need an alliance. an alliance which is not only an alliance between physicians and patients, but also an alliance which has to do with the facilities. We need a new alliance. This is a sort of refrain. Citizens do not pay a healthcare system only because they are taxpayers. They could also become data givers. All the data they share with the hospital contribute to the interventions done and received. So if you are not subject to the choices of the physician, so that the citizen should no longer be the subjects of the decisions by physicians. We need a new profound alliance, and we cover a certain part of the pathway altogether. I know as a man that sooner or later I will have to surrender to something I cannot manage. But if we cover this way together, as people, instead of giving all the power to a platform, well, the NHS will give a value to us all. So we will close this meeting with this very interesting reflection of our colleagues. I would like to thank everybody, and I would like to remind you that the meeting is quite unique, as you've managed to see. It's been unique for the last 42 years, and it was also supported thanks to our donations. So just to remind you that along the halls of the Rimini Fair, you can see lots of desks where you can donate, and the meeting this year will also support a specific project in Kampala. So I wish you all fruitful proceedings, and thank you very much.